after the brainstorming session by ma'am, I don't think my presentation will be of so vast, and it's a very simple, which we everyone as a gynecologist and obstetrician we are practicing. As you know, the sterilization is the most widely used birth control method all over the country, and India was the first amongst the first country who started the National Family Planning Program way back in 1952. The female sterilization forms an integral part of the National Family Planning Program, and around 4.1 million females sterilizations are done annually. As per the district level household survey, third, 34% ever married women accept the sterilization as a contraceptive choice, as compared to only 1% of the male sterilization. The female sterilization is a very safe, simple, and highly effective method of contraception. It carries a very low risk of complication if done as per accepted medical standard practice and guidelines of GOI, Ministry of Health, Family Welfare. There has been always some failure or complication with the procedure which can lead to the litigation. So today I'm going to highlight on the medical legal aspect of the sterilization, and I will be also discussing what is important for we as a obstetrician and gynecologist to know about the guideline and standard protocol of female sterilization so as to avoid the litigation. It will be just as a revision as I said you earlier also. Now, first let us think what are the various issues in the female sterilization. There is no doubt that the female sterilization is about almost 4 times more commonly performed procedure. It's always an elective procedure done on the very young and healthy female. It is never done as an emergency or as a part of treatment of any disease or pathology. And it is only once-time procedure in the lifetime. So any adverse outcome is not accepted by the patient, by the relative, and by the society. Now, the various common reasons for the litigation are either the procedure is done without consent or the consent is not very properly done the way it should be done, and at times the provider is not well trained or has a provider has a inadequate training. Sometimes it happens that the facility where the operation is going on is lacking to deal with any emergency complications. Failure of sterilization is another reason, which can be due to the wrongly performed through, and it can be through the natural recanalization, which is bound to happen after the procedure, and the mortality during the sterilization within a month is also another area of the litigation. It's important to know the eligibility criteria for the patient which can be taken for the sterilization. A thorough assessment of the patient eligibility for the operation is the main key factor to reduce the complication and ensure the quality service. Woman has to be either married or ever married. These eligibility criteria are according to the Government of India, Ministry of Health, Family Welfare. The age varies between 22 to 49 years, and she should have one child at least above the age of 1 year, unless there is some medical indication to go for the tubal sterilization. There should be no history of prior sterilization to either the partner, except when there is a history of the previous failure of the sterilization procedure. The patient should be in the sound state of mind to understand the implication of the tubal ligation, as this procedure is a permanent one, and we have to choose and select the case for the ligation as medical eligibility criteria guideline of the GOI which I'll be just mentioning. Um, the in case of the mentally ill patient, a certificate by the psychiatrist is must, and the statement regarding the mental state of the patient is to be given and recorded by the legal guardian or the spouse. Now, this is the medical eligibility criteria given by the WHO in 2004 for the tubal ligation. A is the accept uh, where there is no medical reason to deny the operation. The C stands for the caution, where the operation can be done in the routine setting, but with extra preparation and precaution. This is wrong, and it like in the cases, the example I can tell you is in the previous abdominal or the pelvic surgery. Uh, uh, the previous history of the previous epilepsy which is on the treatment, there is a past history of the DVT or ISD, uterine fibroid or presence of the PID treated for it, and the patient who are obese, there the special caution has to be taken before taking the for the tubal ligation. Now the delay, there is no reason for any tubal ligation to be uh, cancelled. There can be a delay in operation before we take the case has to be properly evaluated by the investigation, and the proper diagnosis has to be made and the treatment, and then after the patient is being the condition is controlled, the patient can be taken for the contraception. And it is very important, okay, for the time being the patient has to offer the contraception till the operation is done. As is the special condition setting where the operation is done in the special setting with the by a experienced surgeon, where there are the qualified staff is there are proper equipment and facilities for the general anesthesia, the anesthetists are available, and availability of the multidisciplinary team is there. As there are the eligibility criteria for the patient, there are the eligibility criteria for the doctor. I am sure that most of us here in the private sectors are not aware that empanelment under the government of the India Ministry of Health, Family Welfare is a must before the doctor is going to do the tubal ligation, and uh, any to avail the facility of the National Family Planning Indemnity Scheme. And I don't think most of us we know it. In fact, I was also there are the eligibility criteria for the doctor. The for the mini lab tubal ligation, any person who has done the DGO, MD, or MS in OBGY can do it. But the specialist in other surgical field and even require a training in the mini laparoscopic tubal ligation. Though, according to the government of India, the MBBS people, doctors are also allowed to do the tubal ligation, but they have to have a trained certificate in the mini laparoscopic tubal ligation. Laparoscopic tubal ligation, the person has to be, according to the government of India, it has to be trained in the laparoscopic sterilization. Like even the DGO, MD, and MS OBGY need a training certificate if they want to empanel and to avail the National Family Planning Indemnity Scheme. Similarly, the specialist in other surgical field and the MBBS has to get the training certificate for doing the tubal ligation. This I think everyone knows, but just as a revision, the interval tubal ligation has to be done within the 7 days of the LMP. That means preferably in the follicular phase or any time of the cycle if she is not sure, if she is sure of not pregnant, or if she is using IUCD or taking OCP, then the removal of IUCD can be done at the same time, and if she is on the oral contraceptive pill, she has to continue that in that cycle, or it can be done after the 6 weeks of the childbirth. After the emergency contraception or the medical abortion, the tubal ligation can be done. It should be done within the 7 days of the next menses. So she has to wait. Now, the postpartum, the sterilization has to be done after 24 hours to within 7 days of the childbirth. And usually, most of us are doing the tubal ligation along the cesarean section. What happens? Just a minute. Just bear with me because I'm about the MTP or the spontaneous abortion. Tubal ligation can be done concurrently or within 7 days, as per medical eligibility criteria WHO 2004. I like to highlight and emphasize that laparoscopic tubal ligation, that is by using the fallopian ring or even the coagulation and cut, never to be done in the second trimester abortion, with the second trimester abortion, and during the period. And it is advisable to avoid the tubal ligation when we are doing the high risk cesarean section, because we don't know what time the complication can occur during cesarean, and if the sterilization is done, you are liable to be for the family planning condition. Now, the the counseling plays a very important part in the selecting the case, and a general counseling has to be done where the client has to we are providing the patient for the informed choice and about the different type of the contraception, and then he can take the final decision ki what contraceptive method the person has to take. Now, sterilization, we all know that it is a permanent method of contraception, and nowadays, with the one family norm and increasing divorce and remarriage is quite frequently seen. So one can later change their mind, may plan to have a family from another partner. So a detailed counseling is must, and once the patient decides for a tubal ligation, it has to be a method specific counseling. The counseling is done to provide well informed choice, and it has to be a voluntary decision. All the other method of contraception has been explained to the patient. The detail about the operative procedure, whether it has to be a tubectomy or the ligation, laparoscopic ligation, the risk during and after the operation, the side effect, the complication, the failure rate, and patient has to be told about the permanent method of tubal ligation. But a reversible can be possible with the surgery, but there is no 100% success. So all has to be explained, counseled to the patient in detail. The risk of the failure rate and chances of the ectopic pregnancy, which will require a further management, has to be told in counseling only to the patient. And also the counseling is to be done for unsuspected pregnancy with the option of the MTP after once the pregnancy is confirmed by the pregnancy test or the ultrasonography at the same time of the tubal ligation. We have to counsel and explain to the patient that it doesn't affect the sexual life, it doesn't affect the routine daily works, but it doesn't protect the HIV, AIDS, and reproductive tract infection. The patient is allowed to ask the questions, and we have to, with patients, clarify all the doubts before the patient is taken up for the tubal ligation. Also, we have to offer the option of refusal of the operation at any time of the before the surgery, without and the denial to the other contraception. The option of the other contraceptions are always given to the patient for any time. and patient has to be told that there is a provision of the indemnity coverage whenever there is some complication or mortality occurs. The consent plays a vital role in preventing the litigation. It has to be an informed, voluntary consent, and it has to be in the language which the patient understands. Without any coercion, a free willing consent has to be done. And sometimes the denial of sterilization can be done by the patient and by the doctor also, and all has to be documented. Like during cesarean section, we have taken the consent for the patient has given the consent for the tubal ligation, but due to any fetal or the maternal condition ending up into the PPH, the fetus is anoxic or asphyxiated and preterm, very preterm. So in the best interest of the fetus and the mother, we can omit the sterilization operation, but everything has to be documented, and the reason why it was not done has to be also put into the file. Sometimes any unforeseen intraoperative finding that the tube is not traceable, all, and if it has to be done on one side or on the both side it has not been done, that all has to be written and documented in the file. Regarding the consent of the husband, there is a controversy. According to the government of India, the consent of husband is not mandatory, but our other association and organization like NMC, FOXY and ISOG, it is advisable and preferred to take the consent of the husband, and even the legally wherever the reproductive capacity is in future is affected, it is always advised to take the consent of the husband. Before we take up the patient for the clinical assessment is very important, and the most important information is the menstrual history, where the LMP has to be taken and it has to be documented. Any history of the contraception by the patient in form of the IUCD or the oral contraceptive, along with the medical history, which is very important, whether there is any history of the medical illness and she is taking any medication to control the disease, any history of allergy. This will be followed by the thorough physical, general and the pelvic examination, and this gives an opportunity to examine for any pelvic or the genital tract infection also. The other, regarding the investigation, the CBC and urine test are mandatory as per the government of India, but the other investigations will depend upon the medical conditions. Sometimes when the periods and the patient is not sure, the pregnancy has to be ruled out by doing the UPT or the beta HCG, and it all has to be documented. The documentation is very, very important. The patient, when is taken preoperatively, has to be monitored every 10 to 15 minutes by the vitals of checking blood pressure, pulse rate and respiration, and this all has to be documented once again to save from the litigation. Intraoperatively, the continuous monitoring is done, and all the checklist has to be signed by the doctor. It is the duty and responsibility of the operating doctor to do all the proper clinical assessment and properly select the patient before taking for the ligation. Avoid doing tubal ligation in the post-ovulatory phase, especially if not sure of the pregnancy. And otherwise, if you are doing it, because at sometimes the patient are due to the constraint of the time, especially when they are coming from the far distance, but then we can do it, but it has to be documented always. The monitoring of the patient in the post-operative period is very vital. very important. The vitals has to be checked every 15 minutes for 1 hour, and then hourly next 4 hours. Patient can be discharged after passing urine, awake, and at least after the 4 hours of the operation. The discharge card, which the most important, and it has to be having all the details regarding the type of the operation, the details about the any intraoperative findings, and the instructions are to be strictly followed regarding the diet, drugs, and activity as per reference manual for female sterilization, family welfare, 2014. The patient and the discharge card should mention all the warning signs like the fever, vomiting, distension, bleeding from the wound site. All these has to be mentioned in the discharge card, and always mentioned it has to be reported immediately. The follow up has to be done within 48 hours, and day 7 for the stitch removal. The second follow up has to be done after 1 month or next menses, or even if the menses don't return, they have to come for the follow up. And we always write, it should be written that report immediately within 2 weeks of any time she misses the period or suspect pregnancy to avail the facility of the MTP, but it has to be done free of cost. And if the patient doesn't turn up, then she is not liable to for all the expenses and avail the facility of the National Family Planning Indemnity Scheme. Now, regarding the sterilization certificate, it has to be issued only after 4 weeks or after the first menstrual period, whichever earlier. If there is no period after 1 month, the pregnancy has to be ruled out before the certificate is issued. It should never be given if one does the unilateral tubal ligation, which has to be documented. It has to be informed to the patient and signed by the patient. We can give the certificate after counseling for early undetected pregnancy during the tubal ligation operation, specifying its validity is for the subsequent pregnancy and not for the current pregnancy if it happens. As the anything can go wrong during the first 4 weeks of the period before issuing the certificate. So the discharge card is a valid proof of sterilization, especially when the compensation is demanded. Uh, Regarding the various reasons for the failure of sterilization, it can be a technical deficiency where the due to the improper application of the or inadequately performed operation like the tubal tubectomy, or the fallope rings are not applied, a wrong application of the fallope ring on the round ligament or over the a part of the mesosalpinx. These all are the technical deficiency which can lead to the sterilization failure. And now it is well accepted even by the court that there is a natural recanalization can occur. The failure can be due to the underlying pathology intra-abdominally, and already if the patient is pregnant during tubal ligation, which has been documented by putting the last menstrual period, early undetected pregnancy at the time of the operation can be taken as a failure. So always offer MTP or support throughout the pregnancy with good antenatal care is advisable. If the patient doesn't want MTP and wants to continue the pregnancy, it's always preferred to rule out the ectopic pregnancy, which has to be managed accordingly. Uh, I was also not aware that there is essentiality and it is a must for every doctor to avail the indemnity scheme of the National Family Planning, which was started in 2013. Uh, for to empanel of the doctor is also a must, and the amount which are the claims which are provided by the scheme, is that if the death occurs at hospital within 7 days of the discharge, the amount is about is almost to the tune of 2 lakhs. That death, if it occurs within 8 to 30 days of discharge, compensation of 50,000 can be given. Expenses for even the expenses for the treatment of complication up to the 60 days of the from the date of operation can it can about the amount of almost 25,000. And if the sterilization is there is a failure of sterilization, amount of 30,000 can be given to the patient. And the doctors who are impaneled, it is only for the impaneled doctors. If they are sued for in the litigation, so they can be compensated for 2 lakhs up to per case, and up to 4 cases per year is granted in this scheme. So it is advisable for every doctor who are doing the sterilization to be impaneled in the National Family Planning Indemnity Scheme. It is also important that the patient, the institution, the private sector institution has to be impaneled before, if they want to avail the indemnity scheme. Also, the government doctors who are impaneled and now they are retired, they have to apply and get it re-impaneled once they are coming into the practice to avail this facility. There is still exists some controversies and dilemma regarding the tubal sterilization. The consent of the spouse, which I have already mentioned, according to the Government of India, the consent of the spouse is not mandatory. Whether the histopathology of the tube when we are doing the mini lap tubectomy is a must or not, whether both the tube has to be sent or not, there is always a controversy and dilemma for it. Because as it is not must according to the Government of India, the FOXY and the ISOG organization. Whether the unmarried or the nulliparous female can undergo the tubal ligation. There is, according to the FOXY and ICOG, it is the right of the patient and of the to decide about her reproductive outcome. If she doesn't want to have any childbirth, according to them, the patient can be taken up for the tubal ligation. But in case of the government India, it is always has to be tubal ligation with that when we are doing it third cesarean, but it is not a must. The regarding the training certificate for laparoscopic tubal ligation, whether the DGO or the MD or MS doctors has to undergo take this certificate. And now the private sector and the doctors who are working in the private setup are eligible for the sterilization certificate. I'll be highlighting some few landmark cases. This is a very important landmark case of Mrs. Santa versus.
Madam, your presentation is gone again.
I don't know what is wrong. I have to again restart, ma'am.
Restart.
I'm sorry because I'm very new to all this.
No problem. Please go ahead.
Excellent, excellent.
Yes.
This was a lady who was a laborer and had already 7 children. And she got the sterilization done in year 1988. And after 10 years, she had missed her period and she went to the doctor again. But they said, no, there is no pregnancy. And again, after 2 months, when she went there, the doctors there in the government hospital refused to go for the abortion as she wanted, but they said it is risky to the her life, and she has to continue the pregnancy, and she delivered again a female child. And during when the sterilization certificate has given, she was informed about the success of the operation, and she was advised that there will be no pregnancy in future. I'm sorry for the mistake. And so she has the case was filed for the compensation of 2 lakhs, and the defense was there that the only right tube was ligated, not the left tube. The doctor himself who did the tubal ligation has convinced and has reported to the court. So the decision by the Supreme Court was taken that the doctor was held negligence, because it was documented in the file that the only right tube has been ligated. The state government was also made liable for the compensation as a vicarious liability, and the first time the Supreme Court has ruled on the compensation for bringing up the unwanted child. And it was also highlighted by the agreed and highlighted by the Supreme Court that the failure of operation can be due to the natural recanalization of the tube and not for a reason of negligence. Oh, what happened? Now this is another where the consent was not taken. Dr. Janki versus Mrs. Sara Funisa in 2000 at Kerala, where the LSCS was done with the tubal ligation in view by the doctor who was doing the cesarean, that the next pregnancy will be risky to her life. And the allegation was there was no consent for the tubal ligation, and the defense was only that the next pregnancy was risk to the life. Under GA, the consent cannot be taken. So the case went in favor of the patient. Another case of sterilization failure between Shikha versus Dr. Jindal in 2003, where the allegation was about the failed sterilization and compensation was demanded. The defense has said that it was operated as per standard norm, and the inference done by the court was that there is an inherent failure rate of 0.4%, and there is no expert evidence was available that the operation was not carried out as per norm. So the case was dismissed in favor of the doctor. Now again, this is highlighting the importance of the documentation in preventing the litigation. Ravi versus Dr. Usha Rani, the surgeon was called for tubal ligation by the owner of the nursing home, and the patient died on the table. The allegation was compensation for mortality. The defense by the doctor was that the tubal ligation was not done, but the record was contrary, and it was showing that tubal ligation was done. So here in this case, only the surgeon was liable for and the case was decided in favor of the patient. Last, to prevent the litigation, it becomes the responsibility of the operating surgeon to see the checklist before taking up the case for the ligation, and strictly following the protocol and guideline as per Government of India, Ministry of Health, Family Health Welfare 2014. The counseling and informed consent is the main key to the success to prevent the litigation. The preoperative assessment, proper preoperative assessment by thorough history examination, the blood test as needed, and the other investigation needed per medical eligibility criteria, WHO 2004, preoperative proper instruction, detailed documentation of the type of the tubal ligation and the place of the surgery, post-operative care, and detailed discharge summary with proper instruction and follow-up. And always try to manage the complication, even if it is major or minor, whether it happens intraoperatively or post-operatively, and the regular follow-up of the patient is very important. And again highlighting that the documentation and record keeping is very, very important. These are the references from where I have prepared this uh, talk. Thank you so much for your patient hearing.
Thank you, madam. Your talk was very extensive, and I think you covered everything. I would invite all the experts
Very
and
nice.
chairpersons for Dr. P.K. Kohli, sir, your comment, please.
Yeah.